Thank you very much, Jeff. Now I'd like to invite all the faculty to come here. Please take place because we'll have a panel discussion. All the faculty, even the one who have not spoken this morning. And also because you will get your box lunch sandwich here. Don't have to run about it outside. So we'll have a panel discussion which is going to be moderated by Dr. Mike Valentine. He did a good job yesterday. And now David Perloff, you can come here as the governor of the American College of Cardiology for state of Florida, who is going to give talk after that about PCSK9 and here. So, John, everybody come. Tony, all the faculties, please. Mike, Jay, let's get everybody here. Yeah, sure. Yeah. Sagada, get out here. Yeah. Fontaine, there's enough chairs here for all the faculty here. All right. Tom Kelly, I think last year you were the last one in this corner. You get the last one here this year too, Tom. All right. Okay. Come on. Tom Kelly, besides being, great cardiac surgeon who founded the heart program many years ago, is also a board member of the foundation who supported this program. Tom, please, and you can give your talk for them, welcoming them on behalf of the foundation after that. Okay. Anybody from the faculty still here? I'm just looking around here. Fergus, I see, come on. She will be talking this afternoon. She is the past president of the APC and currently associate professor at Mount Sinai, New York. She's a great speaker. You will enjoy her this afternoon. And both, all right. Mark Ball, what happened to you? Are you asleep? Dolan, come to Dolan. Come on. Steve Kopeski, come back. Well, Bill Roberts here. Where's Bill? Is he down here? Or he probably come late. Okay. Okay. I think we'll get everybody seated. Who's busy from the faculty will sit in the front. Okay, now let us go ahead. If you're Dr. Valentine, where are you? You're supposed to.
I'm hiding. All right. Well, this is quite a distinguished panel. When we have more on the panel now than we can possibly ask. So if you ask one question and each panel member answers it, then we're going to bring lunch in here. So if you have questions, I would like you to direct your question, have one person answer the question, because I think that would be best, not that 4 or 5. So at most 2 people, and we'll try to keep our answers short. Yes. And Nanette had a very good comment here a minute ago saying, perhaps after listening to us talk, we as clinicians need to do a better job of taking medicines away sometimes rather than always adding. And maybe that's one of the critical things that we need to think about, especially in our elderly patients who may be at the highest risk. So yes, ma'am.
Dr. Kopecky, regarding familial hyperlipidemia, is there a clinical difference between homozygotes and heterozygotes? And do all people carry the gene have elevated LDL?
Here we go. We'll hand it to him.
Yes, good question. There is a difference. The patients that are people that have the homozygous, they have both genes, and that's like that young man I showed you who has cholesterol levels at 1,000. The heterozygotes aren't as severe. They manifest later clinically in their lifetime. So it's a very different group of patients.
All right. Next question here. Scott, come on. Feel free. Well, while you're thinking, because this is an ideal opportunity to ask some of the best in the world, I'll ask Dr. Ferdinand. You talked today about that you saw 11 patients in clinic yesterday, and we're talking about the SGLT2 inhibitors in your patients. Now, let's just say you have a heart failure patient who's already on 6 medications, and they complain to you that they just hit the donut hole, and you're now going to advise an SGLT2 inhibitor. How do you deal with that, given the cost and the multiplicity of the medicines that patient's going to be on?
That's a whole session we need to have on adherence and access to medicines.
Mm-hmm.
We can e-scribe all we want, paper scribe all we want, patients can't afford the medicines.
Right.
I struggle with that. I think if a person has familial hypercholesterolemia, and I work hard to give them PCSK9 inhibitors, and it's a person with diabetes, if atherosclerosis, high risk for heart failure, I'll struggle and get them the SGLT2. We just have to do it.
Mm-hmm.
There's no other choice. The outcome data are too overwhelming.
Yeah. Excellent. Next question. Yes, we got a question here and then there. Yes, ma'am.
My question is, what would you do, if anything, with a 64-year-old woman who has a naturally normal blood pressure of 90/60, pulse rate of 60, normal BMI, but she has a 300 cholesterol and a history of mother MI and a grandfather with an MI? Would you do anything with that blood pressure?
Okay.
I would treat her cholesterol very aggressively.
Yeah. And you know, there are many people who are walking around with blood pressures who are completely asymptomatic with lower numbers like that. My wife's blood pressure is always 95, and she's never symptomatic. So you leave them alone. Okay, got one in the back. Yes, sir.
Your case presentation, your person had a creatinine of 1.8.
Mm-hmm.
The creatinine clearance, give or take 25, 30 thereabouts.
Mm-hmm.
Aren't the SGLT2s contraindicated, especially EMPA, for creatinine clearance less than 45?
So
and we always have these difficulties with these agents that contraindicated, that difficult to find an appropriate agent to use.
It's not really contraindicated. It's in the label, because that was the cut point that the FDA had to package it. Within the infrared trial, patients could be anywhere up to 30. In the group who are between 30 and 45, they still had good outcomes. He's not completely wrong on that. You can still use it. The GLP-1 doesn't have that precaution, so you could also use liraglutide and inject it.
okay. Next.
And monitor the creatinine, and that's it.
So yes, sir.
I'd like to direct a question to Dr. Wenger in her next hypertension talk with women. There was one slide where you mentioned that pre-hypertension at age 50 predicts cognitive decline. How do you define pre-hypertension?
Again, the pre-hypertension in that study would be defined as between 120 systolic and 129 systolic. So it's not at the treating threshold, but just before that, and it's not at the normal threshold, which is 120. So I think that if you have this as the usual blood pressure and it stays in that range, I wouldn't treat it. The minute it creeps over to 130, I would. And I would let the patient keep a log rather carefully, and very often the pressure goes up and down. And in that particular study, the pre-hypertension, again, because that may be just one of the values in the spectrum that you see day in and day out, did portend cognitive decline later on.
All right, I have a question for Dr. DeMaria and Dr.
Can I make a comment?
Yes, sir.
Too? Because the problem we have is if you rely only on the blood pressure, as Nanette points out, once it's over 120, there is a higher risk for having early vascular disease, which is likely to progress. The question is, the problem is that not everyone over 120 has such a problem. And if you just make a decision to use the blood pressure as the guide, then you're going to treat some people appropriately, and others you're unfortunately not going to be treating appropriately. So we always feel that you should evaluate the health of the vasculature, which means in our parlance, endothelial dysfunction. And about half people with pre-hypertensive blood pressure levels have endothelial dysfunction, and the other half do not. And if you can separate the two out, then you treat those with it and do not treat those without it, and you're individualizing management.
As a matter of fact, it's very interesting. Coincidentally, about 5 years ago, we had some study, as you know, we talked about the program, Dr. Kohn talked about it, and CMC, also, etc. And we studied this group with pre-hypertension. And we already showed the structural function abnormality, and we say pre-hypertension as a disease, and submitted that to the American Heart Association meeting in Washington, D.C., which coincidentally, Keith Ferner was chairing this session. So really, the pre-hypertension is a disease. So that remember that the new name for that is elevated blood pressure. They're trying to get out of this word pre-hypertension.
I would just like to add to that, and I echo what Dr. Wenger and Dr. Kahn said, but let's say this woman is in a high-risk population. So let's say they're African-American, Hispanic, or now we're looking at some of the Asian women. Then when they're pre-hypertension, I would really strongly let them engage in things like lifestyle prevention, managing their sodium, managing their exercise and what they eat, because I think Dr. Kahn mentioned about 50% already have vascular damage, right? When you're pre-hypertensive, I would like to say that perhaps African Americans in particular, where hypertension is a really big issue, it's probably a lot higher than 50%. So you do want to begin to address those issues earlier and more aggressively, because they'll have worse morbidity and mortality. So I just wanted to throw that in.
Excellent. Dr. Fontaine, how do you see the new AFib guidelines, which just came out 2 weeks ago? How do you see those changing practice for the average cardiologist in the United States?
Well, I haven't thoroughly reviewed those guidelines, although I'm familiar with the information that's up to the publication of these specific guidelines. I think if you look at, let's address the African-American population, if you look at the registry data, medical and others, you find that the on-treatment, the time on therapeutic treatment with warfarin, for example, is about 50% or less. And the issue is that these patients are not being protected. We know that compliance with NOACs are much, much better than the 50% threshold value. So therefore, African Americans in particular are at risk for having thromboembolic complications because they're not in therapeutic range or they have bleeding complications. We know that the incidence of hemorrhagic conversion in stroke in African American population is high. So the NOAC, which has been steadily growing in its utility worldwide, several years ago it was only about 40%. Now it's in excess of, it's far in excess of 50 to 60%, I would say. I think the convenience of it, using NOAC, which is what one of the statements in the guideline indicate, there's a favorability towards the utilization of NOAC therapies, which will make things a little bit easier, enhance compliance, enhance adherence to the therapy. So I think there's some value in that aspect of the guideline.
We have a series of patients in my clinic that now, because they all hit the donut hole at about the same time, the Medicare, and then they're screaming. So we actually have a changeover we actually have a series that go to warfarin for 3 months. And I know that that's not ideal, but my patients tell me, I can't afford this medicine when I go in the donut hole, and I will stop it. So we have set up a program to try to transition them as quickly as possible for those 3 months that they're in the donut hole. It's been one of the few ways we've been able to maintain this. Yes.
I think the comment I will add about the new guideline is that it looks like it's incontrovertible now that in preferred agent that we should use in patients with atrial fibrillation to be the NOAC, because when you look at the benefit, there's clear cut that we're trying to prevent strokes, but you don't want to create bleeding. And two, the guideline also addressed the areas of significant lifestyle modification,
right,
especially excluding patients for obstructive sleep apnea,
right,
and other
ask Dr. DeMaria and Dr. Perloff a question, then we'll come back out here. This is an interesting, oh, yes, ma'am.
Sorry. This is for Dr. Saris and maybe Dr. Kelly. I'm a GYN robotic, but I'm just out of sheer interest when you diagnosed the congenital aortic aneurysm. Obviously, the age would be like pediatric or adolescent. Are you using robotic or open heart surgery? And what time requirement is there difference between open heart and the robotic?
I don't think anyone is doing robotic aneurysm repairs. I've done some smaller incision aneurysm repairs, but almost never robotic. It's the technology for manipulating the graft at the same time is just not there. Possible. So this is a true open procedure, and we see them all various ages. From I have someone right now 35 or 37 waiting to go, and we see them up into their 80s and high 80s. So it's a lot of different ages, but it's always a pretty good size open operation, usually about 4 or 5 hours long.
Yeah, this question, then I have one for Dr. DeMaria and Dr. Perloff.
There are 16 people up here talking about high blood pressure and lipidemia and heart failure and arrhythmias, but I haven't heard anyone say anything about magnesium or 43 essential fatty acids, tocotrienols are HMG CoA reductase inhibitors. We have all sorts of evidence for reversing these things, and we're not talking about it, but this is a preventive conference. I wonder if there's any experience here among these 16 people with molecular biochemistry of healing.
And that could be an hour-long or 2-hour discussion. So if anybody's got a reasonable answer
The reasonable answer, we cannot cover everything in the earth, it's a lot of talks. As far as magnesium, definitely has a role. Later on, it will tell you more.
I think that for many of the substances that you mentioned, there are no good studies that say benefit and risk. Many of the studies are observational. And one of the issues is that patients can't take an infinite number of medications. So what you have to do is to say you do the ones that have the strongest recommendations. And I don't think in any of our practice guidelines you're going to find most of the substances you list.
Okay, Dr. DeMaria. Last week I was on call and was paged to the emergency room for a patient by the emergency room physician. He said, I have a patient here, and he described the entire patient, and he said, and I just wanted you to know that the echo is normal. And I asked him, well, who did the echo? And he said, I did at the bedside, and the echo is normal. What do you recommend? And I said, why don't I come see the patient? So when you talk about handheld echoes, the American Society of Echocardiography president and vice president called me last week to say we have a real problem here with billing, with emergency room physicians billing for full echocardiograms and all with handheld small devices. How do you see this going when you see the explosion of smaller devices?
So that's the problem. We don't bill for using a stethoscope, I don't think. and we use it and make decisions. So my view is that the handhelds are largely ultrasonic fluoroscopy. And our emergency room docs have gotten quite proficient at using. They don't have the handhelds. They have the ones on the small carts. But Mike, this is the future. I mean, every doc has a stethoscope, and a handheld echo is a hell of a lot better than that. If in fact they, using AI, artificial intelligence, are able to make it such that you put it on the chest and it kind of directs you to where to get an image, and then you hit one button, and out comes a whole lot of pretty good information. If all kinds of doctors can do it, it's in the medical schools. So
I think the problem, the billing problem is a little bit different. The billing problem is that you can buy these devices inexpensively and then people use them and charge for a full echocardiogram. And I mean, you have to assume that they're gaming the system a bit. And that's going to have to be resolved. Now, for the life of me, I don't know how I'm going to resolve it, but it needs to be fixed.
Dr. Perloff, you're president of the ACC in the state of Florida. This is obviously going to be an issue for everyone about billing and charging, and how does that affect so just any quick answers, or is ACC in Florida addressing these type of issues?
So thank you for bringing this up, because one of the things that we do in the state of Florida, I'm actually going to lecture a little later this afternoon as well, and I was going to show some slides about some of the things we're doing for you. You know, everybody always asks, what does the ACC do for me? So this is exactly one of them. We actually have a payer relations committee, and our chair of that is David Walensky, who is past president of the American Society of Nuclear Cardiology. So he's very well entrenched with the payers. And in fact, we were dealing with a billing issue just recently, if anybody's interested in this. But it seems that when you see a patient in the hospital and do a consult, some of our local payers, and we've tried to push this also nationally just recently, are allowing one consultant, the first consultant that sees the patient, to get paid as a consult, as a new consult. Every other consultant that sees that patient after that first initial consult gets paid as a follow-up consult, with a difference of about $100 in there. And they've been doing this without us knowing it. And we recently have gotten some EOBs to sort of show this. So just to let you know, this is one of the things that behind the scenes the Florida ACC is doing for you, and we're pushing it out to national to see if they're doing it across the country. I think this issue also is going to be a significant issue, because I think Tony's right. You know, people are gaming the system and doing less than adequate, appropriate echocardiography and billing it as such. I think that should not, that's not appropriate. It's not appropriate patient care. It's not good for the patient. And I think it's inefficient and inappropriate use of resources.
We have a question here.
About the magnesium.
Oh.
Dr. Aaron Makos will be talking about the 223.
Oh, good.
I'm not missing anything. Make sure you be there.
Okay. Yes, sir.
Good afternoon. My name is Ike Chinura, MD, PhD student at the University of Arizona. My question doesn't necessarily pertain to prevention, but I think it's still potentially important. The concept of stem cell derived cardiomyocyte therapy in regenerative medicine in cardiology. Does anyone have any experience to speak to?
We published the only study that showed that stem cell therapy, or let's say cell therapy, because they're not getting into the question, but in Lancet, stem cell therapy in patients with end-stage heart disease prolonged life. And that company, after that phase 2 trial, couldn't raise any money for a phase 3 trial because the mechanism of benefit was never shown. In the meantime, there's been the retraction of a couple dozen articles on stem cells, which have been shown to be inaccurate. And that's cast a colossal pall over the whole area. I would say stem cell therapy in heart disease at the moment is radioactive. And it, you know, there's probably, it's going to be like the military. I think that there's a stand down, and everybody will stand down for a little bit. We'll take it up and we'll walk.
One thing I never had the opportunity to thank Dr. Kopecky for helping me at this meeting last year. He gave us instructions on how to fill out the request forms for PCSK9 inhibitors for the patients, how to code, how to list things properly. And I want you to know that I was able to get PCSK9 inhibitors for many, many more of my patients this year, because I listened to what you said last year and how to address this. So any of you that are having problems a lunch is a great time. Yes, question over here.
Dr. Khan, you made the statement yesterday that there was no evidence for exercise and diet in prevention. Would you explain that a little more? Because did you mean there was less evidence than your ABCE business, or please elaborate?
I don't think you mean that literally, to be honest with you.
Well, I did. That is, observational studies have very powerfully shown that people who exercise and people who diet, people who do not get fat, have a better long-term outcome than people who don't exercise, people who are fat, people who eat the wrong things. The problem is that many of those behavior patterns are genetic in origin, and they're not necessarily confirmed by interventional trials. So the effort to document the magnitude of benefit of exercise and diet has been undertaken on several occasions. The most robust was, and I quoted the Look Ahead trial that was published a few years ago, which was 5,000 high-risk patients put on aggressive exercise and aggressive dietary management, which was overseen over years follow-up, versus a randomly assigned group who were not given that intervention. And at the end of the day, after 15 years or so of follow-up, the heart attack rate was exactly the same in the two groups. And that's been the problem. Trying to mount an interventional trial, a controlled, randomly assigned interventional trial, which is the gold standard for documentation of benefit, has not been able to document the magnitude of any benefit. We all believe that there's benefit. The problem is how much of that can be applied to a population when you have a patient come in and you tell them to exercise and diet. First of all, their effort is never perfect. They don't follow instructions. And even if they do and you maintain oversight the way this Look Ahead trial did, they couldn't document there was any reduction of event rate in the intervened population. So the answer is that we don't have data yet to document the interventional effects of diet and exercise.
All right. One more question at the back, and then we're into lunch, so we want to make sure we get you that.
What is the cost of rejection of stem cells for treatment of cardiac diseases?
Tony, you want to try that?
Nothing approved.
Yeah.
Okay, I think at this point in time, with that short answer, we're live.
He said there's nothing to prove so far.
Nothing approved.
Please ask our panelists questions now. You've got them when they come down, so please feel free to grab them and thank you.
The faculty will get to Fox lunch here. The movie Victoria about outside. They should be coming in here. And in about 5 or 10 minutes, please be all of you back here for the next talk. Okay? Thank you.
I'm very excited about this to see the virtual prevention of prevention guidelines.
That's right.
He said, listen to me. He said, listen to me twice last week. I would like to speak right afterwards.
You are Dr. Paul? Dr. Paul? Dr. Paul?
What? Am I speaking?
Immediately after lunch. Immediately after lunch.
Immediately after lunch. Oh, good. What time's that going to start?
I'd hate to try and put a number on it.
First speaking this
Yes, and
Correct.
what that is, that the school might sell very services and all those schools are offering everything. You can't make more than so I'm trying to address that.